months or something like that, which is difficult, then yes, it will definitely help you. But if it's going to take more than 6 months to achieve that, then we don't think it's a reasonable thing to do, and you should actually probably going ahead with your IVF. So fact or fiction, is age more important than body mass index, or is body mass index more important than age? Age is actually more important than your body mass index once you're over the age of 39. But before 39, it's actually your body mass index, which appears to be more important. So for the younger women, taking that extra time does look beneficial. And for older women, it does not. So that was the fact or fiction for tonight. It's kind of a game changer for us because we've always told patients that to optimize their health, they do need to lose weight. But certainly for years now, I've, even without this study, told patients that if they were in their 40s, that it was imperative that we got moving. So we didn't always make them lose the weight unless it looked like it was dangerous or risky. There are still risk factors up there. So once your BMI is up into the high 35 and above 40s, there are definitely much, much higher risks of complications in the pregnancy. And we need you guys to know about that. So it's important, really critical for you guys to make sure that you are taking care of yourselves, because we don't want to run into problems. The one advantage of IVF, we can make your embryos, make you lose the weight, keep the embryos frozen, and transfer them in after with a frozen embryo transfer, which is a great option as well. Okay, so did we lose Instagram?
No.
Oh, okay, because it looked like people are joining. Oh, there we go. Okay, so that's tonight's Fact or Fiction. If any of you joined now or missed it earlier, 2 or 3 things I just wanted to mention again really quickly. Number one, I want to thank everybody for all the well wishes. You guys really went out of your way and were very, very kind. So I did have surgery yesterday morning. My thanks to the doctors and nurses that took care of me here in Windsor. They were all amazing. My wife, my family, my kids, and my office staff, and Mary and Tony Pattinson, who are my colleagues here in the office. Mary was kind enough to be bringing me water all day long. So thank you for everybody wishing so well and all the nice comments. And also, it does look like fertility will be reopening soon. Our Ontario-wide discussion of the CFAS guidelines is tomorrow night. I think we'll be pinning down a time to start at that point in time. So I'm anticipating it will be very, very soon. And the cryo companies are starting to ship now. So we can start moving embryos, sperm, tissue samples, anything we need around. So very, very excited about that. So anyways, on to your questions. I'm excited to answer them. So let's take a Facebook question, I guess, first. I am feeling fine, by the way, for anyone who's asking me. Should I be taking it easier after my procedure? Probably, but I'm too thick-headed to do that. Okay. What is the average waiting list for funded IVF? Or do you still have a lottery system? So we do not have a lottery system. We got rid of the lottery system. It was way too complicated to manage. We have a wait list, a simple first come, first serve wait list. However, it is very, very minimal right now. We are applying to the government. We are pushing them very hard to get us coverage. But it is really quite difficult to do that. And right now with COVID, they basically told us not to even mention it. So we are struggling with that. We're working really hard on it, but it is taking much more time than we ever anticipated or hoped for. So that may be a bit of an issue as we move forward. I got one person saying, go home, you just had surgery, you crazy man. No, I'm still here for you guys. I was seeing obstetrical patients all day. Okay, can a woman with PCOS fall pregnant naturally or through IUI once on medication? Or is IVF the only route for this condition? No. So for PCOS, you definitely don't need to do IVF. In fact, frequently IVF is not the right choice for a PCOS patient because they can get pregnant without it. So you have natural conception with agents that will help you ovulate. So letrozole, metformin, Clomid, these can all be beneficial. In very rare circumstances, ovarian drilling, which is a type of surgery. You can do it with then insemination, or you can do it with injectables, although we have to be very careful with the injectables because the chances of having problems with multiples increases significantly. So no, you definitely do not need to have anything major done in terms of IVF. It's definitely the best option for anybody, let alone the PCOS women, but it's not mandatory by any means. Don't I ever rest? No, I don't ever rest. My husband and I went through cycle monitoring with you back in September. I have PCOS. I'm wondering if it is automatically assumed I'm insulin resistant due to the PCOS, or would that have been told to us by you if it was found in my blood work when we got our results? Not every woman with PCOS is insulin resistant. In particular, thin PCOS women tend not to be insulin resistant. And even some of the women that are struggling with weight don't have insulin resistance always. So normally we would tell you, because I'd mentioned that your insulin level was high, your glucose was high. We're going to start measuring hemoglobin A1Cs now as well. So if you didn't hear me say it to you, I probably didn't find it. So that is that. Can you read the Instagram questions? I'm not actually seeing any. Can you?
I can see them, yeah.
Okay, see if you can see them, because I'm not seeing any questions. I'll see if I can find some. I'm just scrolling through. If not, we will be answering lots of Facebook questions instead.
Can endometrioma ever resolve on its own without treatment?
Oh, that's a great question. Can an endometrioma resolve on its own without treatment? 100% no. There's no natural treatment. There is no medical treatment that will resolve an endometrioma. The cyst wall of an endometrioma, and you can see it on our YouTube video on endometriosis, or even on our Instagram post on endometriosis, is very thick. That's not going away. It has to be surgically removed. You got another one?
Yeah. Can birth control pills lead to development of endometriomas once they are stopped?
Can birth control lead to what?
Can birth control lead to development of endometriomas?
No. Birth control suppresses endometriosis, so birth control cannot cause endometriosis or endometriomas to grow. Now, if you were on the birth control pill to protect you from endometriosis or to treat your endometriosis, and then you go off, there's no question that you may see an increase in the return or the growth of endometriosis, but it would never cause it. It's just going to allow it to grow when it was previously blocking it. I've got one here too. Glad you're doing better. Thank you. Just curious, how long is the wait time for my results of my first natural month of monitoring? I understand if it's a longer wait because of your surgery. No, we're usually able to get back to you after we've compiled everything with your stuff and your partner's stuff within about a month to 2 months. So that's fairly typical for us. Let me jump back to Facebook for a second. I have a bilateral tubal ligation by the Pomeroy technique. How successful will I be in a tubal reversal? About 90 to 95% depending on age. But the reversal part itself will be open about 90 to 95% of the time. So yeah, it's very, very successful. There's no problems with that. And we can definitely get that done for you, no problem. We actually have quite a few people waiting to get that done. So we'll probably be doing them in a surgery center in Toronto and here in the hospital in Windsor. If one needed a script renewed, can we still call the office? Yes, we're in the office every day, Steph, so you can call the office. Does having an internal placenta pose any risks during labor? Crystal, I have no idea what internal placenta is. All placentas are internal. If you mean low-lying or previa, you cannot labor. If you mean an adherent placenta, like an accreta, percreta, increta, they don't cause problems during labor. They cause problems after you deliver. But I don't know what you mean by an internal placenta. Maybe you can clarify it. Let me go back to Instagram.
Yeah, you have one on vitamin.
Hang on. What about those with BMI on the low end of normal? My fertility doctor didn't think it was an issue with my failed cycle. Actually, there is some data, including in that study, which shows that it does appear to have a little bit of an impact. So you don't want to be too low. and you don't want to be too high. You want to be kind of somewhere in the middle. And women that are overweight are still probably okay. So I've never really made an issue of women between the body mass index of 22 to 30. It's once you go over 30 or you're going under 18 where it starts becoming a problem. So if you're underweight, you may need some help. I would definitely try to gain some weight, and I tell lots of my patients to go on a Krispy Kreme diet. What is the highest BMI you feel comfortable treating for someone who isn't planning on doing IUI or IVF, only ovulate stimulation medication? So the risks of a high body mass index are very clearly delineated. For those of you that haven't gone on our website, if you go to www.drvictory, that's drvictory.com, there's a resources tab, and on that resources tab, there's an element for weight and infertility. And then if you scroll to the bottom of that, there's a long download, which can show you all of the risk factors. It is very significant. So once your body mass index is over 40, we actually tell patients to try and lose the weight. Again, it's tempered by age, but if your BMI is over 40, it really is not that safe to get pregnant. So we don't feel comfortable at that point. We want you to lose the weight. But again, age has to be a factor. Your ovarian reserve has to be a factor. There's a lot that goes into it. So it's never cookie cutter medicine. We always individualize for you guys. Nice to hear about you doing well post-surgery. Thank you. What about the men? Does their obesity affect fertility either for him or her or an embryo's quality? That's my wife asking that question. Hi, honey. So yeah, it does. So men that are obese, and we've talked about this before, have a significant decrease in fertility success because they produce less sperm, less quality sperm, and they have higher DNA fragmentation. So we know that for sure it does impact things. That's a great question. Thanks for asking that, Wendy. And we definitely encourage the men to lose weight as well. I never tell just the women. I always tell the guys to do it as well. There's an impact from heat in the testicles, excessive sweating, poor blood flow, hormonal changes. All of that can have an impact. So that's a really good question. Lots of likes for Wendy. I love you, honey. So throw up some hoopla. Okay, back to Facebook, I guess. I'm just...
You don't see the vitamin question?
No.
Vitamin D.
Between D2, D3, I'm getting there. Okay, if you have does preeclampsia and HELP get worse with each pregnancy? No. Preeclampsia and HELP actually get better with each pregnancy. Your camera did that thing. So preeclampsia and HELP actually get better. Frequently, if you have it in the first pregnancy, you won't get it again. But we do monitor you very carefully, and every woman that's had preeclampsia or HELP should be on aspirin from before they get pregnant in order to reduce the chances of preeclampsia and HELP again. If you have preeclampsia, will you always have protein in your urine? No. Or is there cases where there is none? Bought test strips to home monitor in between visits while checking BP daily. Good job, Crystal. So no, you will not always have protein in your urine after the pregnancy, but while you're preeclamptic, you will if it's true preeclampsia. By definition, it's high blood pressure and proteinuria and then edema, swelling in your tissues. So that's part of the definition. You have to have protein in your urine. So yes, there's usually protein in your urine. I am wondering what adding an autoimmune protocol to my next FET would look like with Humira. How long before FET to start? How often? And does it continue throughout the pregnancy? I am 28, have stage 4 endo that has been excised in 2019, thyroid under control with Synthroid and some thyroid antibodies. I've had 3 FETs ending in miscarriages before 7 weeks. I am so sorry. For my upcoming FET, added doing a 3-month Lupron shot and taking aspirin, but current clinic doesn't offer immune protocol, and I am wondering if I need to be doing more. That's a great question. So first of all, with stage 4 endo, you should be on Lupron and letrozole. Your thyroid antibodies need to be very, very low, which is very critical. You need lots of vitamin D, selenium, that'll all help. So all of those things are really critical. Make sure you're taking all of that. And I would probably say if it's stage 4 endo, you may even want to consider extending your 3 months of Lupron into 6 months. Autoimmune protocols can involve Humira. We talked about this last week. So there is Humira, there's IVIG, and there is tacrolimus, and then steroids as well. So we don't use Humira and IVIG. It's very difficult to get, and it's insanely expensive. But if you want to DM me on Instagram, I will send you the protocol sheet for that. If you want to look at doing steroids, that's very easy. And we use intralipids, which we call poor man's IVIG here, which is way, way less expensive and seems to have an equivalent effect. So you don't necessarily need to invest a fortune in order to get the same impact. They are not as strong as Humira, but it does work fairly well. So I would advise you consider that. Okay. What's the difference between vitamin D, D2, and D3? Does it matter which one you take and how much should I take? Currently breastfeeding. Take D3, which is the most active version of it. And you want to take 2,000 units a day minimum, up to 4,000 units a day. And then get your levels checked, because some women don't absorb it very well. And sometimes we need to give them the 50,000 unit a week pill, and then they absorb it better. Would I recommend a second ovarian cystectomy for an endometrioma if the first surgery was conservative and only drained the cyst? Okay, so if somebody only drained your endometrioma, they did not really do very much for you. It actually does nothing. The cyst will refill very, very quickly. It has an 80% recurrence rate within a month or two. So we never do that. At least I never do that. I always excise the cyst. So depending on what the rest of your fertility history is like, yes, I would consider removing it. I am a believer in removing endometriomas, but it does weaken your ovary, and that's very important for you to know. So it's not a great option for everybody. Some people should, some people should not. What factors into the timing for using progesterone after ovulation, and do the suppositories, if used too early, prevent ovulation? Oh, that's a great question, Morgan. No, so it doesn't prevent ovulation, it prevents pregnancy. So progesterone used too early is birth control, literally birth control. That's what the birth control pill is. It's mostly progesterone with estrogen added in, so you don't have the side effects of the progesterone. So if you start your progesterone too early, it's birth control. It's going to prevent you from getting pregnant. Progesterone is used to stabilize and support the lining of your uterus. And in doing so, it prepares the lining for the implantation of the embryo. So you very much want to make sure that you're starting it at the right time. So if you're using an ovulation predictor kit, the right time is 2 days after the positive ovulation predictor kit. If you're doing something like insemination, the day after the insemination. So if you've been triggered, we usually start it the next day. For IVF, you got to talk to your center and see what they do. We have a very specific regimen for our IVF cycles, using both injectable and vaginal progesterone. And by the way, if anybody tells you to take it orally, it's useless. It only has 10% of the bioabsorption. Was that vitamin question you wanted me to answer?
Yeah. So
is it always important to remove fibroids when trying to conceive with or without fertility treatment? The fibroid I have is diagnosed as subserosal pedunculated. Okay, so I'm going to draw you guys a picture. So there are very numerous versions of fibroids. So there are ones that are on the inside of the uterus, and those are called subserosal. There are some that are in the wall of the uterus, and there are some that are outside. So hopefully everybody can see this, my chicken scratch. So this is your uterus. This one, which is inside the uterus, is a submucosal or intracavitary. This one is called intramural because it's in the wall. And this one is pedunculated or subserosal if it's kind of partially in the wall. So pedunculated and subserosal has zero impact on your fertility. Unless it's causing enough pain or discomfort to interfere with having sex, it's not going to impact your fertility at all. Intramural affects your fertility only if it's huge. And by huge, I mean at least 4 centimeters, usually even bigger than that. Or you have multiple ones which are accumulating into sort of a compressive effect where it's distorting the inside of the uterus. If you've got a submucosal fibroid, you must have those removed. So even if part of it is in the cavity and part of it's in the wall, or all of it's in the cavity, that is 100% increase in miscarriage and a 50% decrease in success or implantation. So all of those need to be removed. So hopefully that answers that part. Spoke with my nurse today since baby movement decreased, and she said I have an internal. Oh, no, she didn't say internal. She meant anterior. It's in the front wall. So that's the placenta question. So it's not an internal placenta. All placentas are by definition internal. It's anterior. So anterior is your front and posterior is your back. So an anterior placenta means you won't feel the baby move as much. A posterior placenta means you do feel the baby move more. But anytime you're worried about the baby not moving, if you're past 24 weeks, lie down with your hands on your tummy, eat something or drink something sweet. You should lie there for 2 hours. The baby should move 10 times. If the baby does not move 10 times, go to the hospital and get checked out, guys. How do you recommend tracking ovulation? Is basal body temperature better than the OPKs? No. I recently purchased the OvuSense monitor. Why? How thick your sheets are, how hot your partner is, and I don't mean physically looking at them. I mean how temperature hot they are. How warm your body temperature is. Generally, it's totally useless. None of us use it. Ovulation predictor kits, unless you have very bad PCOS, are very, very successful at monitoring. So that is a much better way to go. Usually they can get pretty accurate, about anywhere from 93 to 97%. Do we need a referral to come see you? Yes, please, unless you're not from Canada, in which case you can contact us and we will arrange for a consult. Let me go back to Instagram. Trying naturally now. I had preeclampsia. That's okay. Go on aspirin if you're trying naturally, and vitamin D, and start your aspirin before you get pregnant. Otherwise, it's too late. Is a saline sono always part of your diagnostic testing? Yes, it's always part of my diagnostic testing because I want to make sure the inside of your uterus is normal. You don't have any polyps or any fibroids in there. I want to make sure your cervix is open so that the sperm is actually getting in there. We have to make sure your tubes are normal, and we want to have a good look at your ovaries to make sure there are no cysts or anything. The first pregnancy, should I be taking Advil now? No, not Advil. Advil is contraindicated in pregnancy, so do not take Advil. Take aspirin, Ecasa, enteric-coated acetylsalicylic acid. Do not take Advil. No Motrin, no ibuprofen. Those are all the same thing, Advil. Does taking vitamin D increase your risk for kidney stones if you've had stones in the past? Not vitamin D, calcium will. That can do it, but not vitamin D. Okay, let me flip back to Facebook. I suffered with hyperemesis gravidarum for my 2 live birth pregnancies. I'm very sorry, that's a rough condition. I am wondering if I am likely to suffer from hyperemesis with every pregnancy, having had it twice. Does it get better, worse, or stay the same with every pregnancy? What is the best known treatment to make it through? Okay, so you may have it again for sure. It's highly likely if you've of the infant. So if you had girls before, sometimes it's better or worse. Sometimes it's better or worse with boys. And then if that's still not working for you, there are pretty good treatments. So Zofran is safe in pregnancy and tends to quell the hyperemesis quite well. So we have treatments that we can use for you. So excited, things are opening up. Will your office be calling us? Yes, we will be reaching out to everybody who's been waiting, but you can call us too, and that'll put you in line. What birth control do I recommend for patients with PCOS? Is letrozole an option? We would love to conceive, but deal with azoospermia. Okay, so letrozole is definitely not birth control, as you know. It'll actually help you get pregnant, but not in a situation where you have azoospermia. Lorena, you already know that, but I'm just saying that for everybody else. Letrozole will make you regular as long as it works for you, and that's a totally reasonable choice for patients that want to go ahead and get pregnant again. For patients that do not want to conceive, the best are either Yaz or Diane 35 because they are the most anti-androgenic birth control pills, and those are the ones that are good for PCO because most PCO women have androgenic symptoms. If someone was to look into more donor eggs, hi Mary Lou, what would be the timeline from acquiring eggs to transfer? So from the time we put you in touch with the agency till the time you get an embryo transfer, you're probably looking at about 2 to 3 months on average. Hopefully that answers that. And thank you for joining. It's good to see you there. Okay, how does a growing uterus during pregnancy affect ovarian cysts? Could it lead to ovarian torsion? Is ovarian cystectomy an option during pregnancy if it's causing trouble? Wow, that's a good question. Okay, so normally a cyst less than 10 centimeters will not tort, but once they're over 5 centimeters, they do have a higher risk of torsion. So if you have a cyst that is over 5 centimeters, you probably want to get that dealt with. Now, endometriomas are different because they stick to everything. So endometriomas don't often tort, although they can, but they're so sticky that they don't usually tort that often. Something like a dermoid cyst or a serous cyst can tort or cause torsion of an ovary. Definitely, you do not want to operate during pregnancy. First of all, it's much more difficult. Second of all, most physicians will open you up because they will not feel comfortable trying to do it laparoscopically. And thirdly, it can cause miscarriage even if you're later into the pregnancy. So do not get surgery while you're pregnant unless you absolutely have to. My RE and regular endo offered discrepant information on this one. So I'm curious about your opinion. What is the relationship between untreated Hashimoto's and repeat miscarriages? I don't know why they disagree. The data is very clear. Hashimoto's with high antibody levels increases your risk of miscarriage. There's lots of studies that have demonstrated that. We actually have a fertility factor fiction on it and a couple of posts way back. What was that, like ages ago? Yeah. So take a look at our previous ones and look through our posts, but there is no question that if you have uncontrolled thyroid disease and or you have antibodies, your risk of miscarriage is definitely higher. It has to be dealt with. When can IVF procedures start to be booked? Or are they still being booked during COVID? We're going to start once we know when they're going to let us open. So I'm hoping in the next couple of weeks. What would be caused by chromosome inversion? Yeah. Okay. What is the success rate for a natural IVF cycle? Oh, that's a great question. So success rates for natural IVF with us have been around 40%. That's a little higher than normal. Most of the time, if you read the literature, it's around 20 to 30%. We've done very well with it. I don't know if it was because our previous embryologist was really good or we just selected the right patients for it, but it can be very successful. It's not always successful by no means, but it does do very well, generally speaking. So we've done quite well with it. You're the best. Thank you for all you do. Hope to see you soon. I hope to see you soon too. Thank you for saying that. Okay. Is a saline sonohystogram better than a hysterosalpingogram? Yes. So a hysterosalpingogram is when we take you to the hospital or I guess a radiology center. We have to put in a speculum. We normally have to pinch your cervix with a tenaculum, which is this thing that holds on to it. You then have to flush cold dye under a moderate amount of pressure because it's thick, it's very viscous, into the uterus and up through the tubes. It does give you a crystal clear picture of whether your tubes are open or not, but it is not fun because it is painful. The cold makes your uterus and your tubes often spasm. We're then trying to break through the spasm. That ends up hurting more. It's not a good thing for most patients. On top of that, you get no information about fibroids. You don't get any information about the ovaries, and you get minimal information about the fallopian, about the cervix. With a saline infusion sonohystogram, there is no radiation. It's way more comfortable because we keep our fluid heated and all of our instruments heated. I inject very slowly because it's just water, so it's not painful at all. And then just a few air bubbles. At most, you get a light cramp. None of our patients ever complain significantly. And we actually have a video on YouTube at Victory Reproductive Care showing a patient getting a live saline infusion sonohystogram, and she doesn't complain about a thing. And I asked her multiple times, and she says she's fine throughout the whole thing. So definitely always go for an SIS over an HSG. There is no reason to get an HSG. It's kind of dinosaur medicine. I'm on bromocripta something. It's bromocriptine for high prolactin levels. Hypothetically, if I were pregnant, when do I stop taking it? Around 12 weeks. So if you're on bromocriptine, you should stop around 12 weeks and then it'll go back to normal. It won't actually go back to normal immediately. It'll stay on an increasing path because you need prolactin to make breast milk. So as you go through the pregnancy, your prolactin levels will get higher. After the pregnancy, we never know. Sometimes it'll come back down to normal. Sometimes you'll need the prolactin again. Sorry, the bromocriptine again. I missed the first part. Is my office opening soon? We're not sure, but we're finding out tomorrow. So tomorrow is the Ontario-wide conference call with all the fertility specialists to see when we're actually going to reopen. Any tips on prep or good diet before FET transfer? Wow, we've done a bunch of the FET prep stuff on our fertility factor fiction. In brief, so very healthy diet, Mediterranean diet in particular has been proven to be beneficial. Melatonin is beneficial. Vitamin D is beneficial. So all of those are really important. Lots of exercise, very low stress. Jen Strong, our naturopath, will tell you that you should consider acupuncture, and I'm a believer in that. If it de-stresses you, I think that's beneficial as well. I think that you also need to make sure that they are getting your lining ready appropriately. There's lots of monitoring. We're big believers in monitoring progesterone levels. I do think that makes a difference, although some people say it does not. So all of that is really important. Make sure you're doing all of those things, and then you got to make sure that they do a good embryo transfer for you. A lot of people do not know how to do a great embryo transfer, and that's critical. In some cases, the uterus is flipped upside down. It's called retroverted or retroflexed. And when it's like that, it is very difficult to see abdominally. So in those circumstances, you definitely want to do a transvaginal ultrasound-guided embryo transfer. So the ultrasound is going in transvaginal instead of on your belly. I don't know a lot of people that know how to do that. There are some. We kind of pioneered it and really became very proficient at it. So I do that every time, and we get a beautiful view of where the embryo is going. So that's something you should definitely consider. What is the success rate for IVF with sickle cell patients? Ooh, that's a great question. It can be quite high. If you're both sickle cell, you would want to screen out your embryos using something called PGT-M, which is pre-implantation genetic testing for a monogenic disorder, where we can make sure that your embryo does not have sickle cell. So if you yourself have sickle cell, we do need you on medications to make sure that you're not going to run into a crisis, and then you need to be monitored during pregnancy very carefully. It is safer to use a surrogate, but it is possible for sickle cell patients to get pregnant and have successful pregnancies. So that's definitely doable. I think I've exhausted everybody's questions, guys. Oh, we're 10 minutes early. That's good. All right. And the last one was good luck on the conference call. Thanks for answering all these awesome questions. Well, thank you guys for sharing. I want to thank everybody. We are almost at 4,000 followers, so that's amazing. Tell all your friends. Definitely like, comment, subscribe. The more you do, the better it is for us, the more we can get out of it for you guys. So make sure you tell me what we can do. Oh, here comes some more. This happens every time. There's always people that get in their last minute questions. Oh, YouTube, here we go. Hi, Jess. What happens if your day 3 FSH is over 13? Can it be lowered naturally? Is it still possible to conceive? What are my options? And at what point is a donor egg necessary? Okay, so Jess, it is possible to get pregnant. We don't really follow FSH that much. We follow AMH a little more, but we never treat you because of numbers. And no one should ever treat you because of numbers. You should be treated based on what the data and the evidence is. So the evidence is best for women with strong ovarian reserve, but that doesn't mean that women with weaker ovarian reserve can't get pregnant. So we need to look at a lot of things: your AMH, your FSH, how many follicles are there, how old you are, what your body mass index is. There's a lot of factors that go into it, and we use all of those to decide. You can definitely still get pregnant. When is a donor egg necessary? A donor egg is necessary when you feel that the chances of getting pregnant are not high enough to justify the cost of the IVF cycle. For me, that's when the chance starts falling below 15, 20%, but that's just me. For you, it might be a different number, and we're willing to work with you for whatever you want to do. Oh my gosh, there's so many. They're all pouring in now. Can phytoestrogenic foods like soybeans and grains worsen endo? No, in fact, there's some suggestion that it can improve it. So phytoestrogens do not function exactly like normal estrogens. Do you have anything on your website that walks us through what to expect with IVF? Yeah, there's a whole section on IVF. And Tarek and I were going to work on on a video. Maybe we can do that, a whole walkthrough of what it would be like.
Yeah, it's very
Your laptop is on battery saver mode now. I don't know if that's important or not.
That's important.
So we'll create a video this weekend, assuming my kidney is functioning. Can genetic testing be done on already frozen embryos? Yes, it can. So the prior embryologist I worked with always used to say that it couldn't be done and it was a terrible idea. And I had no reason to disbelieve him. My current embryologist says the exact opposite, that it's actually quite practical and reasonable to do, and that she's done it quite a bit. So we can do that for you, and it can be done safely. And she says she's still got good success rates with it. Oh, here's a good question. How did I decide to go into the fertility field? You seem absolutely amazing from these videos. You wish you were in Alberta. Sorry, I'm not in Alberta. We actually thought of going to Alberta initially, but it didn't work out for a variety of reasons. So I love helping people and I love babies. And I figured making babies would be the best way of helping people and getting a chance to engage in that. I love the field. I think it's really amazing. And I feel that too many patients don't get enough information or the right information from their fertility specialist because it is big business. And that's why we do this. I actually was asked by one of my patients recently why I'm giving away all the trade secrets for free. Why aren't we actually, saving all of these and only using them for ourselves? I'm not interested in making more money. I'm interested in having more patients that succeed. And whether you're with me or you're with someone else, as long as we can get you to where you need to be, for me, that's a win, and I can go to sleep at night knowing I did a good job. So, I'm good with that. That's a win-win situation for me. At Kaiser, I was treated because of FSH, Kaiser Permanente. Yeah, I know Kaiser. So no one should be treated for an FSH level. You shouldn't never be treated as a number. I mean, we don't want anyone treated as a number. Yes, there are risks, and if your FSH is climbing, or certainly if it's really high, like over 20, then that portends a poor outcome or lower success. But we never treat you just because of a number. So I'm not going to tell you, oh, you can't do this or you can't do that because you have an FSH of this or an AMH of that. Going back through our fertility fact or fiction, you'll see AMH is not always the be all and end all of fertility, and definitely FSH is not either. How important is it for men to give up drinking beer? It's hugely important. It's an 83% increase in their risk of abnormal sperm. Sperm DNA fragmentation goes up, their testicles shrink, and it causes cancer. So it's very important to give up drinking beer. Is losing weight for healthy BMI and following your release every 2 to 3 days enough to make an improvement in sperm? Losing weight. Yeah, I mean, if a guy is losing weight, that definitely will help. And you want to have him ejaculating every 2 to 3 days and loads of vitamins. All of those are important. It'll undo some of the damage. Our sex education only focuses on pregnancy and STD prevention. Young adults need to be taught more about reproduction than what we teach students in high school. I couldn't agree with you more. I have actually gone to schools to talk to students before. It was quite amusing. You don't want to know about that story. And Mara, if you're watching, I'm sure you remember Ken's story on that one. Do you have a list on your website of safe anxiety, depression medication to be on while trying to conceive? Okay, so there are no 100% safe anxiety, depression medications when you're trying to conceive, but you need to balance the risk of your anxiety and depression against the risk of the medication. Typically speaking, it's not that high a risk, but there are lung and heart risks that can come along. So we tend to be very cautious with them. If you don't need them, don't use them. If you do need them, by all means, use them. I think we're winding down. Is it possible to unblock tubes with the use of supplements and Chinese herbs? 1,000,000,000% no. I see this all the time online. You cannot unblock your tubes with herbs. It is impossible to do that. The herbs can't even penetrate where they need to go. So no, you cannot use herbs. Is that rain?
Oh, no,
Can you hear
I
that?
think it's the laptop of the family.
Oh, maybe I hear running water or
I
something.
heard it.
Yeah. Which Toronto clinics will I be working at in the future? Right now, Create, and we're looking forward to working with them. So I'm hoping that materializes soon. I'm waiting to hear back from Dr. Liebrecht. I didn't get much information. I am sorry, Sundaywood Cottage, you didn't get much info. I'm available to you, so reach out to us. Yes, yes, and yes. I'd have you in my class in a heartbeat. Oh, I'm willing to come. Talk to Mara. She'll set it up. Is it necessary to continue taking vitamins throughout pregnancy if they were started beforehand? Not coenzyme Q10, but all the other ones, yes. You should be on your pregnancy vitamin because baby is sucking everything out of you. Okay, we're getting down to the last one. My doctor has recommended growth hormones for my next cycle since I don't want to use donor eggs. What's your opinion? Growth hormone actually has randomized controlled trial evidence that demonstrated that it increased live birth rate, so it does work. So you should use it. What are the names of the reproductive immunologists I work with? Fred Disneku and Chloe Roumain, and they're a husband and wife team. Does coenzyme Q10 help with egg quality? Yes, it does, if you use it long enough. Okay, guys, how can I find out how my fertility ranks among others? I don't know about others, but you can find out where yours is. You just have to come in and get tested, and we're happy to do that for you. Okay, we got 20 seconds left, so I have to sign off. I thank you guys all for asking your questions and participating. Please, please, please spread the word. We want everybody watching. If you're on blogs, if you're on chat groups, if you're on IVF Canada, make sure you let everyone know. We're happy to work with you guys. Take care. Have a great night. We'll see you soon. Bye. Share the story. 160 viewers on Instagram. That's really good. That's like a high for us. Oh yeah, we're still live. Where is it? Yeah. Oh yeah. Oh. Okay. Adios. Adios, adios, adios. I think we're off on everything. Oh wait, are you sure you want to end your end stream? Yeah, I'm sure.